then that from 2017, I collaborate with Professor Wernovsky, and we manage several meetings in our center. And this year, we were ready to do another meeting for a congenital heart case, but due to coronavirus, it was not possible to do this meeting. So the idea is to stay together, to share experiences all over the time, trying to involve some good friends, some colleagues from all over the world, because I believe that probably Italy was suffer a lot. We paid for the first, at the same, for the second of China, the price of this enormous disaster. It's a very big opportunity for us to stay in contact with all the people, because we are still in lockdown. Everybody is paying this strange situation, but our feeling that nothing can stop the science, nothing can stop the support to help our patients. So thanks a lot for everything. It's a big pleasure for me to introduce Professor Gil Wernovsky with the first presentation about how many consultants we need to manage such a very complex population of patients affected by isomerism or heterotaxia. Professor Anderson will explain more and more how to will help us how to move in this very difficult world. But the pandemic disaster bring us a very big problem with more than 150 colleagues that passed away in Italy. And I would like to share with you one video that our Matteo Arrigo prepared for this special situation.
Mute your phones, everyone. Sasha, please turn up the volume on your video, please. Sasha, if you can, please turn up the volume of the video.
There may not be any sound.
He's muted. I'm trying to unmute him.
I've seen the video. It's quite beautiful.
Gil.
All right, Sasha, you are unmuted and we see you.
Yes. So now it's time for Gil.
Can't hear you, Gil.
Hello. I think working in intensive care is a lot easier than this. I can't seem to get this into slideshow mode. Ah, there we go. Can everybody see my slides now?
You're good, Gil.
All right.
Yes.
Good morning,
Yes,
everybody.
okay.
Good morning, and as Sasha said, good afternoon, good evening, whatever time it is where you are. Just a few minutes, I wanted to talk about outside the chest and outside the heart on how many consultants does a patient with heterotaxy need, and I think that will become apparent as we move forward. I wanted to introduce this with the concept of pleiotropy. And what pleiotropy is the fact that a single gene or single gene mutation as organogenesis is happening can result in multiple traits during the development of the fetus and even, in fact, during postnatal life. The ciliopathies are characterized by pleiotrophic clinical features, and these mutations which disrupt ciliary function can lead to both developmental or degenerative phenotypes in most tissues of the body. And while this doesn't represent every case of isomerism or so-called heterotaxy that we're going to talk about today, as time goes on, we will learn more and more about this. So although we started out thinking of heterotaxy or isomerism as a way to classify the complex congenital heart disease, which is mainly a problem of sidedness, we're learning that it's a whole body disease. It's got both primary and secondary manifestations, and that's why you need a large team to best care for these patients. This is an example of some of the work that's now well over 10 years old, electron microscopy of cilia that are beating in unison. This happens early on in embryogenesis and helps with the left to right differentiation of the fetus. We've learned that cilia are responsible for many things. This is one of the things that we've learned about here in the United States, and you'll see that it is quite similar. This is what disordered cilia look like. They're not beating in unison, and these result in asymmetry and organogenesis, as well as functionality disorders. It's good to see them side by side, with normal on your right and disordered on your left. Oh, I forgot about that. I wanted to go outside the USA. So we're going to talk about the whole body disease very, very rapidly. I do want to mention to everyone that this is being recorded. These slides will be available for you to re-look at. They're not downloadable. It's intellectual property of the speakers. But a bibliography has been prepared of 30 broad overview recent papers that may be of help to you. So we're going to talk about each one of the organ systems very rapidly in terms of disorders of formation, disorders of function, and then if the children have heart disease, what happens secondarily because of the heart disease. If we start off with the brain, we know that there are structural abnormalities of the cerebellum, which tends to be small. Absent corpus callosum, again, another midline defect, is not uncommon. In rats and mice, abnormal synaptic connections have been described. It's not yet been described, except in one paper, whether handedness is effective or whether our math and artistic parts of our brain follow the same sort of sidedness pattern in patients with isomerism. And then if we add that on top of patients who may require intensive care, abnormalities of fetal flow, and cardiac surgery, we see the same pattern in about 2/3 of the patients. Please mute your phones. 2/3 with developmental abnormalities, gross, fine, and oral motor delays, and we don't have time to get into this. This could be an entire symposium. So early on, I would recommend that when babies are admitted to your care, that early on we involve genetics as well as people who will follow the baby for neurologic development, as well as imaging of the central nervous system. If we move further down into the mid-face, midline defects such as cleft lip and palate, micrognathia, choanal atresia, high arch palate, laryngeal cleft, and in patients with a primary ciliary or secondary ciliary dysfunction, frequent sinus infections, and frequent otitis media. So it's not uncommon that as an outpatient, babies or children might need an ear, nose, and throat consultation, as well as checking their hearing with chronic otitis. I suspect Bob and others may talk about the abnormal bronchial arrangements in this disease, but there is a higher incidence of pulmonary infection, mucus production, bronchiectasis, and obstructive lung disease. If we look at the congenital heart population, when they have congenital heart surgery, there have been reports of a longer duration of mechanical ventilation for patients with isomerism compared to other diseases, a longer amount of chest tube drainage in patients who get a Fontan operation. And in late, it's been shown that the kids have restrictive lung disease, probably from sternotomies and thoracotomies, as well as the early development of pulmonary hypertension. Pulmonologists may therefore be important to your team. If we move below the diaphragm, again, lateralization abnormalities in the stomach, liver, spleen, gallbladder, pancreas have all been reported. TE above the diaphragm, TE fistula, absence of diaphragm, diaphragmatic hernia, atresia of the major midline structures, and in some, the portosystemic shunts associated with Abernathy malformations. The function, however, is important, especially in terms of splenic function with the increased risk of bacterial infections, low immunoglobulins. There have been rare cases of diabetes associated with agenesis of the pancreas and thrombocytosis with an increased amount of systemic emboli in the Fontan population. And this all gets together again in the early neonatal population with feeding abnormalities and failure to thrive. So many of your patients may need consultation from gastroenterology or immunology. Many of us who deal in the inpatient area certainly worry about malrotation of the small intestine, or so-called non-rotation. Interestingly, despite this problem, there's a surprisingly low incidence of volvulus, and it's somewhat controversial as to whether these new wounds, volvulus, these patients are in the intensive care unit, and it's somewhat controversial as to whether these patients should have a prophylactic LADS procedure. The kidneys may have structural abnormalities as shown here. There's been rare cases of fused adrenal glands, as well as horseshoe kidney, single kidney, etc. They have been associated with hypertension, particularly if there are renal vein or renal artery obstructions. And then for the congenital heart disease population, we know that, especially for complex neonatal pump procedures, that acute kidney injury occurs in 40% of these patients, and the long-term implications are just being discovered. It's not uncommon for us to involve nephrology in this group of patients. If we move into the genitourinary or the genital system, we know that abnormal cilia can be associated with both infertility and sterility. As these patients get older, they might, the males might need consultation from a urologist, females from OB-GYN. And then as the patients grow up, of course, with adult congenital heart disease, in addition to all of the other challenges they have with a chronic disease, and you'll hear about this a little bit later on, it's important to remember that mental health growing up with a chronic disease of any type, not just congenital heart disease, is important to pay attention to. So this is the list of the types of consultations that you need. And I guess what I would emphasize is, as you work on a program to take care of patients with isomerism, it's better to have one pulmonologist see 50 patients than 25 pulmonologists each see 2 patients. Partner with someone who gets to know the disease so you can talk on the same terms. So I'll summarize with this. As a baby, in addition to our congenital heart surgery team, early on in the ICU, neurology, genetics, development, general surgery. As kids become outpatients and occasionally earlier, GI, immunology, ENT, pulmonology, and nephrology may be necessary, and in the adult population, as you can see here. None of this is a substitute for an interdisciplinary comprehensive cardiac team. Dr. Agati was kind enough to send me a picture of his team from Taormina, which involves, of course, anesthesia, cardiac surgery, cardiology, intensive care, and nursing. This is necessary but insufficient, as we've talked about. I want to, before I finish, I want to mention that the next master class that Dr. Agati is organizing takes place on May 13th. We'll hear about this more. It'll be the first part talking about hypoplastic left heart syndrome, starting from the fetus, palliative care, early imaging and morphology, surgical considerations for the standard approach and hybrid approaches will both be discussed. And then I'm very excited to announce the confirmed faculty of our master series that we're working on with Lowell Frank, looking deeply into key trials in our field. We discussed the Primacorp trial about 3 or 4 weeks ago. This trial was run by Rick Oye, Chief Cardiac Surgery in Michigan. He'll be joined by Sarah Tabbitt, Jane Newberger, Jim Tweddle, and Karen Goldberg, who ran the single ventricle reconstruction or SVR trial #1, as well as #2, which was in the early toddler years. And Karen Goldberg is conducting SVR3, so we can have results between 6 and 10 years out from this landmark trial. We invite you all to tune in, and more information will be following from this. I'm pleased to introduce the next speaker, a good friend of all of us, and well known to all, Professor Robert Anderson, seen here with the fish he caught that said was 10 kilos. Many of you don't know Bob Anderson. This is his good friend Anton Becker, has been defining morphology for us and has been a landmark professor in the field for decades. I was fortunate enough to witness this détente between himself and my mentor, Dr. Richard Van Praagh, and I can tell you honestly that as much as I learned a lot from Dr. Van Praagh, Dr. Anderson has convinced me of the utility of the term isomerism in this disease. Dr. Van Praagh also trained Paul Weinberg, who I worked with in Philadelphia, and here's Bob and Paul Weinberg listening to one of my lectures. The last thing I'd like to say about Bob is, since we're talking about isomerism, this is Bob, and then this is mirror image Bob. And you can see how close they are to each other, even in the mirror arrangement. But we can also look at left-sided Bob. So this is bilateral left-sided Bob, and this is bilateral right-sided Bob. Either way, he'll be giving us a fantastic description of the morphology of this complex disease. And I'm pleased to introduce Professor Robert Anderson, who will now share his screen. We hope.
You won't let me. Says I can't share mine until yours is off.
That's my bad, Bob. I should be off now. Lavia, please mute your phone.
Now it's okay?
Okay, am I on?
Yes, you are, sir.
Okay, well, thank you very much. What a great introduction, and it's a pleasure for me to join you all in this terrible time. It's in fact worse now in the United Kingdom than it was in Italy, and we are about to take over, I think, with the greatest number of cases in Europe, which is not a good thing, but it's great that we're all together. So it's my place now to discuss isomerism versus heterotaxy. So what is there to know? Well, it's all here. And I'm sure the editor-in-chief of this volume will support me in saying that we have everything to go. I hear criticisms that this is an all-male panel, so you'll be pleased to see that in our book we have Kathy Massate representing the females and also the nursing profession, because we have to move to a global approach as we're doing in this webinar. So isomerism versus heterotaxy. which approach is of the greatest clinical value? I'm biased. I think that it all depends on the appreciation of isomerism. But what I'd like to do in the 20 minutes or so that I'm going to be spending with you is look at the evidence. I'm going to start with the meaning of words, because that is how we communicate. But what I'm going to concentrate on is the best way that we stratify the subgroups, because we know that whether we're talking about heterotaxy, whether we're talking about isomerism, there are two major subsets of this syndrome, and the question remains as to how best we can describe them, how best we can understand them. So let's get to the nitty-gritty and let's look at the words. And I refer you to this excellent review that was produced in the Korean Circulation Journal quite some time ago now. And Dr. Kim has summarized very well the background of what we're talking about. So here, very nicely, you see the definition that he's provided for heterotaxy, Greek word, and as you see, an abnormal arrangement of the thoracic and abnormal organs, which is not the expected, usual, or normal arrangement. Now, if we take that at face value, then unequivocally, those who have a mirror-imaged arrangement would be heterotaxic. So what is the definition that we as cardiologists use as heterotaxy? And this comes from the nomenclature working group. I'm privileged to be a member of the nomenclature working group. And this is the definition that we provided. Again, an abnormality where the internal thoracoabdominal organs demonstrate abnormal arrangement across the left-right axis of the body. Gil's just given you an excellent overview of the background to all of this. But even if we consider an abnormal arrangement across the left-right axis, still those who have the mirror-imaged arrangement would be heterotaxic. But for better or worse, the working group have excluded mirror imagery from the setting of heterotaxy. So, as I said, that leaves us these two subsets that we might include within so-called heterotaxy. I'm not going to give them names at the moment because what I'd like to discuss with you is how it is best to segregate and to describe these two subgroups. And I think everybody knows that my own bias is to consider them in terms of isomerism. Well, here is a picture that is showing you an isomeric arrangement. How do I know this is true? Because it comes from Wikipedia. And this is the definition of Wikipedia. What we are talking about is those entities that are related to each other by a reflection. They are mirror images of each other. And the key point here is that when we think about isomerism, we are thinking about isomerism in the same individual. Because in the broadest sense, the patient who has mirror-imaged arrangement is the mirror image of an individual with usual arrangement, but that is in two separate individuals. What we're talking about here is mirror imagery within the same individual. So let's go back to Dr. Kim and let's look at this excellent definition that he has provided for isomerism. And as he says, structures that are themselves mirror imaged. And when we think of the congenitally malformed heart, it is the syndrome in which we have morphologically right or morphologically left structures on the same sides of the body in the same individual. And I can illustrate that very nicely by showing you the dorsal surface of my hands. There they are. And the hands are the exemplars of bodily isomerism. And indeed, if we all think of our own bodies, the parietal components are isomeric. They're not necessarily exactly the same because one side may well be larger than the other in terms of the work it has to undertake. So the question we are discussing in today's webinar is whether in the setting of heterotaxy, we can see evidence of isomerism. And Gil has already given you the lead that I'm going to start by looking at this in terms of bronchial arrangement. And I'm indebted in this regard to have these images prepared by my very good friend and colleague, Shumpe Mori. Now, Shumpe was a cardiologist who was working in Kobe. He's now, in fact, moved and he's locked down at the current time in Los Angeles. But these are the images that he produced for me quite some time ago from the patients he was working with in Kobe. And here you see the usual arrangement of the bronchial tree. And we know in this usual arrangement, the right-sided bronchus is short. It gives off its first branch before it is crossed by the pulmonary artery supplying the lower lobe, making this bronchus epiarterial. If we look on the other side, the left bronchus is long, and it is crossed by the artery supplying the lower lobe, making the first branch of the left bronchus hyparterial. Compare that to this situation, where here we see that the right bronchus is long, it has a hyparterial first branch, the left-sided bronchus is short, and it has an epiarterial first branch. This is mirror-imaged bronchial arrangement. In fact, in this patient, all of the thoracoabdominal organs were mirror-imaged, and going along with that, we see that the apex of the heart is pointing to the right, rather than as it would normally point to the left. But here are the conditions we are discussing today. In this individual, again with a right-sided heart, but the presence of a heart in the right chest tells us nothing as to what's going on inside it. But what we can see in terms of the bronchial tree, both of the bronchuses are short and both of the bronchuses are epiarterial. This is right bronchial isomerism. So here we have another of Dr. Mori's patients, and here both of the bronchuses are long, both of the bronchuses are hyparterial. The apex of the heart in this instance is more or less pointing right down. We don't know what's going on within the heart. What we do know, this individual has left bronchial isomerism. But as Gil's pointed out to you, isomerism or heterotaxy can involve all of the bodily systems. And we specifically today are going to be talking about what is happening within the heart. And the question remains, can the heart exhibit isomerism? Gil's also introduced you to the controversy that existed for quite some time between myself and Dr. Van Praag. Dr. Van Praag arguing that isomerism is no more than a useful mnemonic when we come to analyze the heart. And indeed, Dr. Van Praag has questioned whether we can really have isomerism within the heart. So Gil has also introduced you to the importance that comes from molecular biology. So let's look at what happens when we knock out some of those genes, which, as Gil has informed you, are responsible for the left-right organization within the body. So this is the undersurface of the atrial chambers. It's a scanning electron micrograph. It's made by my very good friend and colleague, Nigel Brown. We're looking at the undersurface of the atrial chambers in this mouse in which PITX2 has been knocked out. And PITX2 is responsible for morphologically leftness. So in this heart, when there is no gene to produce leftness, we have atrial appendages that have the features of morphologically right appendages on both sides of the heart. The mouse, in this instance, unequivocally has isomerism of the right atrial appendages. And let's look at another one. In this instance, the mouse was prepared by Dr. Meno in Japan. He was kind enough to share this histologic section. This time, we've knocked out, or he has knocked out left 1. When you knock out left 1, you remove a midline barrier, and now you permit HIT-X2 to go to both sides of the embryo and to make it morphologically left. And here within the heart, we have morphologically left appendages. So I put it to you that the evidence now from the molecular biologists shows us that at least in mice, isomerism is a real thing. The question we have to discuss today, however, is whether we can recognize isomerism in the postnatal heart in individual. And it is the atrial chambers that show the features of isomerism. So the question then, how do we distinguish rightness from leftness in the atrial chambers? And so here I come back to another of the principles that was introduced by my very good friend, Richard van Praag, because Richard said that when we are looking within the heart, we should identify structures on the basis of their most constant components. And here is the letter that he wrote to Circulation as long ago as 1980, when we were discussing how to define ventricles, and that was when he established this notion of the morphological method. And ever since that time, we've tried to use this principle when looking at the congenitally malformed heart. So let's apply the morphological method to the atrial chambers. And so which is the most constant atrial component? And it's not necessarily the most obvious. Now, Dr. van Praag would tell you we should use the venous connections. But let us take an example where we might want to use the venous connections. Here is the heart. The heart has been flipped out of its pericardial cradle by the procedure that's called the Taussig maneuver. And what you can very nicely see now are the pulmonary veins. And the pulmonary veins are turning south. So if we use the pulmonary venous connections as the arbiter of the morphologically left atrium in this particular patient, it would be the liver that would become the left atrium. And that obviously is a no-no, because as you see, still we can recognize the left atrium. And particularly in the setting of the syndrome we are discussing today, it is not possible to use the venoatrial connections to identify the atrial chambers. And I'll come back to that as we proceed in our discussion. So we know that the appendage is the most constant atrial component. The question then is whether we can distinguish rightness and leftness on this basis. So if I show you images of the normal heart, I think it's relatively easy to recognize that what you see to your left hand is the morphologically right appendage. It's like the map of India upside down. In the normal heart, it's easy to distinguish that from the morphologically left appendage that looks like Snoopy's ear. But when, quite some time ago now, we used this as a means of differentiating between the appendages, Dr. van Praag made the very good point that shape can be altered by abnormal hemodynamics. So we asked ourselves, is there a more reliable means of distinguishing between the atrial appendages? And it was my good friend and colleague, Dr. Hideki Uemura, who spent some time working with me in London in 1990, who pointed out that if we look at the extent of the pectinate muscles relative to the atrioventricular junction, then to your left hand, you see the morphologically right side of the heart, and there are the pectinate muscles going all the way to the crux. To your right side, you see the morphologically left atrium, smooth vestibule, the pectinate muscles contained within the appendages, within the tubular appendage. And when Dr. Uemura took 182 hearts with so-called heterotaxy, and he looked to see if he could distinguish bilateral rightness, bilateral leftness, or unable to distinguish the appendages with certainty, when he used the pectinate muscles, there was clear distinction between morphological rightness and morphologically leftness. And I show you just some examples here on the right side of a heart, of a patient with heterotaxy, and on the other side, you see two blunt appendages, isomeric right appendages. Compare it with this situation. Snoop is here on the left, Snoop is here on the right, morphologically left appendages. And we've followed up that since. We've looked at a large number of hearts from centers in North America, from Toronto, from Gainesville, Florida, from Chicago. And in these also, when we take the extent of the pectinate muscles, always we have found it possible to distinguish our usual arrangement, pectinate muscles to the crux on the right, smooth vestibule on the left, mirror imagery, pectinate muscles to the crux on the left, smooth vestibule on the right, or the two isomeric arrangements. So it is now our firm belief that when we take hearts in our hands, we look at the arrangement of the pectinate muscles, always it is possible for us to start the analysis of the heart, basing it on atrial arrangement with these four patterns. It remains to be seen whether this can be done in a clinical situation, but as we become more and more experienced, and as resolution of clinical techniques get better, I believe that is the case. But we should emphasize that it is the appendages that are isomeric. It is not the entirety of the atrial chambers. So when we talk about isomerism within the heart, we should talk about isomerism of the appendages. And what it means is that when we analyze what's going on, we need to take note of the variables. And perhaps most important of that, for those in this setting, is the veno-atrial connections. But everything else is important: AV junctional morphology, ventricular morphology, and so on. We need a full sequential segmental analysis. But it is the veno-atrial connections that determine how the blood is coming back to the heart. And it's certainly true that when we find isomeric appendages, or when we look at patients known to have heterotaxy, we don't know what is going on about the venous connections. So we need to describe them sufficiently well that we remove ambiguity. And we must recognize that on occasion, the connections in themselves may produce venous drainage that is very similar to normal. We can call that quasi-normal, or it is very similar to the mirror imaged arrangement, quasi-mirror imaged. But if the appendages are isomeric, that does not mean that the patient has so-called cytosolitis or so-called situs inversus, because within the heart, it is the isomeric appendages that are the starting point of analysis. And then it is the case that if we look at the combination of lesions seen within the heart, we can make broad plans to distinguish the two subsets. So if we now consider the two subsets in the setting of isomerism, remember that this is usually also reflected in bronchial arrangement. So if I take the subset of right isomerism, what am I going to expect? In most instances, there will be bilateral superior cable veins. Each will look like a normal right superior cable vein. So always, and this is universal, always in the setting of right isomerism, the coronary sinus will be absent. So that means the coronary veins themselves will drain directly to the atrial chambers. And that is another feature of right isomerism. What is often not appreciated is that always when we have bilateral morphologically right appendages, there will also be, in anatomic terms, totally anomalous pulmonary venous connection. It doesn't mean that the anomalous venous connection will be extracardiac. In fact, it is to systemic veins in about half of the cases. In the other half, the pulmonary veins will come back to the heart, but they will do so in anomalous fashion, rarely directly to the atrial roof, in the fashion 4 pulmonary veins to the corner of the right-sided atrial chambers, more frequently to a midline confluence. And these are the patterns of veno-atrial connections that should have you thinking about right isomerism. So what about the counterpart? What about left isomerism? Oftentimes in left isomerism, there are bilateral caval veins again, but this time they look like the morphologically normal left superior caval vein. So typically, one will come back to a coronary sinus, the other will look like an unroofed coronary sinus. And usually the coronary sinus is present, but on occasion, both veins can be unroofed, and then once more, the coronary veins will drain directly to the atrial chambers. Frequently, the pulmonary veins will drain in symmetrical fashion because the atrial chambers are trying to be morphologically left. We will expect interruption of the inferior caval vein because the inferior caval vein is a morphologically right structure, but that is not always present. On occasion, there can be an inferior caval vein, but more usually the hepatic veins drain directly. They too can have an infradiaphragmatic confluence. So if I summarize what is going on, there are still some who suggest we should analyze it in terms of situs ambiguous. But is there really any such thing as situs ambiguous? Not if we describe each system of organs and analyze them separately. So in the lungs, the bronchial tree, I've already shown you. We have the 4 basic arrangements, usual, mirror imaged, the 2 isomeric arrangements. The spleen, as Gil has said, is of great importance. The spleen can be solitary, multiple, it can be absent. Gil has emphasized the importance of intestinal malrotation. So for sure, we need to take note of that, everything else that's going on within the abdomen. But if we come back to the heart, then on the basis of the appendages, there will be either right or left isomerism in the setting of so-called heterotaxy. So is there any ambiguity? Not if we describe each of the systems, remembering that they are not always in harmony. And that is the bottom line. We remove the ambiguity by describing each of the systems. So no question, the syndrome exists. It's of considerable clinical importance, but I put it to you, if we classify it into its right and left isomeric subsets, describe what's going on throughout the body, recognize that the systems are not always in harmony, then we remove any ambiguity regarding heterotaxy. So I'll pass on from there and on to our next speaker.
Thank you very much, Bob.
While we're taking a break and getting the next speakers set up, I want to be sure we don't go too much past what would be 11:30 on Eastern time, because we got started a little late with technical things. So I'd remind speakers as best you can to see if we can get us back on track, and tell the audience that we will probably go over a little bit and hope you remain interested. Sasha, do you want to introduce the next speaker?
Yes, I don't see inside Emre Belli, so it's a big pleasure for me to introduce Professor Kirklin, that has a very long experience and coming from Alabama, and recently he published a very big paper about isomerism and the new surgical approach management of this such complicated population of patients. So with big pleasure, I introduce Professor Kirklin. People who is not interested in the presentation, can you please close the video? And also the...
Sasha, I think that Emre was logged in under my name, so we'll try to get him back on. But Dr. Kirklin, I believe you're up.
It's better to start with Professor.
Sure. It's a little out of sequence on my program, so I will share.
Well, this is all about out of arrangement, so I think that's perfectly fine if we move the program around.
Sure, no problem. Now you can see my screen.
Yeah, if you could put it in slide, there you go. Perfect, Jim. That's great.
Okay, great. Well, thank you all very much. It's truly a great pleasure for me to participate in this very, very interesting webinar. And I have no disclosures. So in order to provide a little perspective on surgical management of this rather diverse and often complex constellation of congenital malformations, as Dr. Anderson has so nicely summarized, I would like to review with you our 25-year experience with heterotaxy at UAB Children's of Alabama. Between 1990 and 2016, you can see we operated upon 103 consecutive patients with heterotaxy undergoing cardiac surgery. So 31 were classified as right atrial isomerism, and I'm going to call this right isomerism for short for the remainder of this talk. 64 were classified as left isomerism, and in 8, neither left nor right isomerism could be established. So looking at the patient characteristics, a few things are noteworthy. First, single ventricle physiology was somewhat more prevalent in patients with right compared to left isomerism, 72% versus 55%. Total anomalous pulmonary venous connection, TAPVC, was present in 29% of patients and was 4 times more common among patients with right compared to left isomerism. Interrupted inferior vena cava was present in 68% of left isomerism patients versus only 19% of those with right isomerism. This table describes the initial cardiac operations. Nearly 60% of heterotaxy patients underwent their first operation as neonates, and this was more common among patients with right and indeterminate isomerism. Greater variation in the type of first surgery occurred in left isomerism, whereas the vast majority of patients with right isomerism had initial operations which included either repair of TAPVC or a modified Blalock-Taussig shunt. So among the 30 patients in the overall group with TAPVC, 70% underwent repair at the initial operation. This table examines operations in the single ventricle pathway, which accounted for 68% of the patients. Among the 70 patients in this pathway, by the end of the follow-up period, just over 25% had completed the Fontan procedure. Another 11% had a Kawashima without a subsequent Fontan, and 63% had another palliative procedure in the single ventricle pathway, which was the final operation during the follow-up period. This depiction shows the survival for the overall surgical group with the parametric and Kaplan-Meier survival curves above and the hazard function or instantaneous risk of death below. You can see the increasing mortality over time in this complex group of patients, in that over the 25-year period, the 1, 5, and 10-year survival after the initial cardiac operation was 78, 66, and 52%. By multivariable analysis, repair of TAPVC at the initial operation was the only risk factor identified in the early phase, while moderate or severe AV valve regurgitation, as well as male gender and biventricular repair, were the risk factors in the constant phase. So let's look in a little bit greater detail at some of these risk factors in a risk unadjusted sense. So these are Kaplan-Meier survival curves, and they are stratified by the presence or absence of repair of TAPVC at the first surgical procedure. Note the high early mortality of 27% within the first several months after repair of TAPVC at the initial operation. This figure looks at survival stratified by the presence or absence of moderate to severe AV valve regurgitation, which was present in 13% of patients at the time of presentation. And this was always in the setting of atrioventricular septal defects. As noted in the multivariable analysis, the major effect of AV valve regurgitation was in the constant phase, and note the reduced survival at 3 to 5 years. If we compare survival by isomerism, survival was superior among patients with left isomerism, as shown here in the blue curve.
O zaman çekeceğiz. Bu 250'lik yetmez.
Failure to identify, if others could mute their phones, that would be wonderful. Failure to identify right isomerism as an independent risk factor for mortality may in part relate to the very high correlation, as noted by Dr. Anderson, between right atrial isomerism and extracardiac total anomalous pulmonary venous connection, which occurred in 42% of right isomerism patients versus 10% on the left. Here we see survival stratified by combinations of isomerisms and the presence or absence of repair of TAPVC at the first surgery. Note the particularly poor early and midterm survival among patients with right isomerism who required repair of TAPVC at the initial operation, with 46% survival at 5 years. If we compare survival with 1 versus 2 ventricle strategies, there was no difference in survival according to a surgical strategy before risk adjustment, which is shown here. However, after risk adjustment, the multivariable model did identify an increased risk with 2 ventricle repair in the constant phase. We get some insight into the possible reasons for this in the next slide. In this figure, we depict survival after the final single ventricle procedure during follow-up. Note the improved trajectory of survival among those patients selected for a Fontan procedure when compared to survival of single ventricle patients who did not reach so-called stage 3. The 10 and 15-year survival after Fontan was 85 and 75% respectively. So in conclusion, this analysis of over 100 patients operated upon over a 26-year period identified repair of TAPVC at initial surgery as a major risk factor for early death, and important AV valve regurgitation as the major risk factor in the longer term. Patients with single ventricle physiology completing the Fontan operation enjoyed excellent 10-year survival. This experience suggests that heterotaxy patients with single ventricle physiology should be evaluated closely for the possibility of moving them through earlier stages of palliation to increase access to the Fontan procedure. Initial management of right atrial isomerism requiring early repair of TAPVC remains challenging. And for this high-risk subset, alternative strategies such as early referral for cardiac transplantation evaluation at least warrant consideration. Thank you very much.
Thank you, Jim.
Thank you, Professor Kirklin. I would like to invite Lorenzo Galletti. I don't see him, but if he opened the...
Do you have me, Sasha?
Yes. Okay, here we are.
He's logged in with my name. Lorenzo, you look much better than me.
Yeah, even less, Gil. Good afternoon to everybody. Good morning for our American friend. Many thanks for the invitation, and congratulations, Dr. Kirklin, for to show us your experience that huge span over a quarter of century. Very huge number, very good results. Your research confirm and fix what we normally know about this population. First, single ventricle lesion is more common in right isomerism rather than left isomerism. And prognosis is particularly poor in patients that have total anomalous pulmonary venous connection and common AV valve. Even if the phase of risk is different for those patients. You identify the TAPVC as an initial risk for this patient, and common AV valve rather in the late phase of late hazard risk phase. Regarding TAPVC, to me are two the fundamental problem. One is in the newborn age, in which we have to fix and do a complex palliative operation during the newborn. But the second point is over the follow-up, we really have problems sometimes to decide which vein are obstructed because it's a matter of flow. So obstruction that could not be evident for a gland could become evident for a Fontan operation, just increasing the amount of flow. And that is one of the problems to me for those patients. Regarding the AV valve function, the AV valve function is true that most of those valves are particularly malformated valve with 4, 5, 6, 7 leaflet, and the surgical solution could be complex and in most of the case palliative, because no good solution over time. The other point, in some cases, we don't know how is the contribution of the ventricular function to the dysfunction of the valve, if it comes the eggs or the chicken before. And sometimes there is this problem. A final comment, even if Gil told us that is not an issue, but maybe it's not an issue to fix, but as consequence is a presence of bilateral bilateral cavo. That is probably not a problem for patients that underwent 2 ventricle repair, but could be a problem for patients that have single ventricle repair, because F2 gland it could be the cause of a central pulmonary artery hypoplasia that could be finally an issue for a Fontan operation. So I don't know what is your opinion about the topics that I raised. Thank you.
Yes, thank you very much for those comments. I agree completely with all of your statements. We looked in this analysis for improvements over time. The situation is better, excuse me, in the more recent years, but by multivariable analysis, it continues to be a challenge, particularly when TAPVC is present and requires operation early. I think the thing that is of interest, that in a large study by the Society of Thoracic Surgeons, they, like all of us, have noted that when heterotaxy is present for most cardiac malformations, the risk seems higher, which is not surprising, realizing the complexity of the anatomy. But what is very reassuring is it's interesting how successful the Fontan operation is. I think that when we all analyzed and reviewed these cases over a quarter of a century, we were, of course, a bit disappointed to find the relatively small number of patients, 25%, who went on to a completion Fontan. Now, of course, that includes an additional 11%, so overall a third of the patients at least had a Kawashima, if there was an interrupted inferior vena cava with azygous continuation. But it is apparent that a large number of patients appear stuck, sort of captured in in the single ventricle phase at some earlier period of palliation. And so that's an ongoing area of interest as to why all of those patients are stuck, but there are many reasons, some of which you have alluded to with imperfection anatomically for completion of the Fontan. But at least if you can complete the Fontan, this is a particularly favorable group of patients for long-term outcomes with the Fontan procedure.
Thank you both. I wanted to take just a second to put some perspective on all these Kaplan-Meier curves and parametric curves that are individual patients on a line. And I'd like to introduce you to a friend and colleague named Alicia Wilmoth, who is a physician assistant at Cincinnati Children's Hospital Medical Center, has worked with Dr. Jim Tweddle in the operating room and is now working on the cardiology floor. I asked her to spend just a couple of minutes talking about just a couple of practical things about, is my screen going up there, Lowell? Can people see this slide?
Yes.
Yes.
So I met Alicia, like many of us, through the network, through the various meetings and whatnot. And she was kind enough to send me a few snapshots yesterday of her work. I know one of these was in Africa, and I don't know if one of them is with Dr. Tweddle or not. Alicia has a very unique perspective, being also on the patient side. She sent me these pictures as well, and I want to turn the microphone over to Alicia. Lowell, would you maybe take care of that and get her on the main video screen? I see you, Alicia.
Can you hear me?
We can.
Oh, there we go.
Thanks for
Hi, everyone.
Thanks for taking a few minutes to talk with this group with a unique perspective on this webinar.
So hello, and thanks, Dr. Wernovsky, for inviting me to just pop on for a few minutes here. Like he said, my name is Alicia. I am a 40-year-old heterotaxy, unbalanced atrioventricular canal pulmonary atresia patient. I have been practicing as a physician assistant for almost, I think, 11 years. As of July 2019, last year, I worked for 8 years as a CT surgery physician assistant, and I currently just switched over to cardiology consult service. As a heterotaxy patient, I think that the perspective of listening to this is it's all been very confusing for me. And it's reassuring to know that I'm not the only one, even though I do have somewhat of a medical background. It's when I listen, people often ask me how I can sit through things and hear about mortality and morbidity. And I've taken the perspective that I've been hearing this since day one, so the longer I live, the less I kind of listen to it. I obviously do take it in and appreciate it and make my own judgments, but I find a lot of encouragement in knowing that I can skew the curve, or I have been skewing the curve, and it's great to hear things that having the Fontan has prepared me for a long life. Obviously, I'm 30 years post-Fontan. I had my Fontan when I was 10. So knowing that, it's awesome. And I'm also aware too that I am very blessed, being that even though I have heterotaxy and I've had some minor complications with GI issues or symptoms, the fear of a possible torsion at once, since I did not have the lead procedure, that I have ultimately come out unscathed, and I appreciate that. So that's just kind of my little bit. I appreciate all of you coming together to discuss heterotaxy, because from a PA perspective, I know that consultation, we always kind of use the word, here comes the train wreck. And so it's nice to know that I can be a little bit of hope in that conversation.
Thank you so much, Alicia. I mean, I was struck by one of the things you said to me one time, is that you have obtained informed consent for every procedure you have had yourself. And I think that's really an incredible statement. And you really are a message of hope to people on this call. So thanks very much.
Thank
I
you.
want to turn this over to my colleague at Children's National in Washington, Dr. Lowell Frank. Lowell is the president of the Society of Pediatric Cardiology Training Program Directors and has helped put this and other webinars together. He also, thank you, Lowell, has also been responsible for muting the phones of people who come in. Like, what did you describe it as? Whack-a-mole when they come in, so thanks.
International whack-a-mole.
International whack-a-mole. I'll turn this part of the rest of the program over to you.
Thanks, Gil. Welcome, everybody. I hope you're enjoying the excellent speakers so far. Like Gil said, I work with him in Washington, D.C. at Children's National Hospital, and I'm president of the very difficult to say FRCPath, and I do see a number of other U.S. fellowship directors on the line, and I hope everybody is really enjoying the wonderful session so far this morning. I'm going to be a little bit of background on the Training Program Directors Society. Give me one sec.
Am I still sharing?
Nope, we're good.
Okay.
Can you guys see my slides?
Yes.
Great. So the Society of Pediatric Cardiology Training Program Directors is a group of the 63 ACGME accredited US Pediatric Cardiology Fellowships. All told, we enroll about 150 new pediatric cardiology fellows per year for a total of about 450 at any one time. And there are an additional few dozen senior clinical fellows in catheterization, electrophysiology, imaging, heart failure, transplant, pulmonary hypertension, and other cardiac subspecialties. Even though there is not geography in our name, it actually is just the American Fellowship Directors. And one of the reasons that I'm putting this information up there is to make the offer that perhaps there's opportunities for collaboration with international pediatric cardiology training education. Our board is pictured there. So our programs are across the continental US, and our current leadership is represented by Lori Armsby, who is the vice president and is based at Oregon Health and Science University in Portland, Oregon on the West Coast. Susan Etheridge, who is our current treasurer and secretary, who's at Primary Children's Hospital in Salt Lake City, Utah. And David Brown, who's our past president, who's at Boston Children's Hospital in Boston, Massachusetts. In addition to running our individual programs, we've collaborated on a number of educational projects that have resulted in really nice publications. We did some work making standardized rotation evaluations for cardiology trainees and linked these to the American Board of Pediatrics and ACGME competencies for all of you who needed to live through that transition. We've done a workforce assessment, the most recent iteration of which came out in 2015, and we're beginning the next workforce assessment now, although perhaps now is not the best time to assess our workforce. There have been 2 iterations of training guidelines, the most recent version of which in 2015 was co-sponsored by the SPC-TPD. The original Pediatric Cardiology Fellowship Training Guidelines came out in 2005. And we've done some work writing the entrustable professional activities for the field of pediatric cardiology. So all I wanted to really say about the SPC-TPD, I want to thank all of our speakers and panelists who are here today. And if anybody is a pediatric cardiology educator and would like to collaborate with our training program directors group, feel free to email me. So with that in mind, I am going to introduce, actually, there's one thing. Gil, should we do the polls right now? Do we have time?
Yeah, that's a good idea.
So Dr. Anderson was kind enough to put together a couple of polls, and since I am an educator, we want to keep this as interactive as is reasonable with 520 people current on the line. So there's 2 sets of 5 true-false questions, and Dr. Anderson is watching, so be careful with your answers. So you guys should all see that on your screen. I'll leave it up for about a minute. You have to enter all 5 and then you submit.
I don't think people signed up for a test when they were signing up for the webinar, Professor Anderson. So we'll see how this goes.
I don't think people like it because I don't think anybody has finally submitted all 5 true false yet. So I'm looking for some more rapid test takers. All right, so I'll leave that up for about another 30 seconds. None of the answers are coming through on my end, so I just caution you we may have a technical glitch here, so I apologize if that's the case.
Yes, it doesn't seem to be submitting.
I hit
Mine
submit.
did, so I'm not sure where the problem is. We'll learn this as we move forward with these, I'm sure.
And on our screen, the third question has only true, no false option.
Oh,
Scroll down.
oh yeah, scroll down.
Were you able to scroll up, Jim, or no?
So I'm gonna
no,
I'll give it another couple seconds, and then we'll see where we're at. All right, so in the interest of proceeding, I'm going to end this and see if anything shows up. I did not get results to show up, so there may have been a technical glitch, and I apologize for that. Usually this works
They're
quite
showing up now, Lowell. We see them on the screen.
You see the results?
Yes. It doesn't say how many, but Bob, do you see them on your screen so you can comment? They need to unmute Professor Anderson.
Yep.
Yes, people like to include mirror image arrangements.
I apologize to everybody from leaving the meeting immediately after my presentation. I pressed the wrong button.
Professor Anderson, we had some technical difficulties showing the percentage of people who answered in various ways. Would you mind walking us through the true-false questions you offered us?
Correct. So I expected people to say that heterotaxy should include mirror image arrangement, so that's encouraging. And again, I didn't specifically speak about this during my presentation. I guess I should have, since I set the questions. I didn't realize they were going to come up. But again, I don't think it is possible to create clinically significant groups on this basis. We need to describe it, of course, but we need to describe it separately because it does not always go along with, perfectly in the two subsets. And then here it is indeed the case that it is only the thoracic organs that show evidence of isomerism. So this is a little disappointing that people thought that was false. Then the remaining two, very good. Specifiers, obviously I didn't convince everybody, but we're doing pretty good when over 9/10 accept that we can gain specificity as it suggests. The things disappeared. But the last one was also pretty good. I'm looking at Lowell now, so.
Great, thank you for that. And it appears in a bit of irony, I am the only one who can't see the results. So now we have our second poll following up with the theme of isomerism. And so there should be 5 true-false questions there. So scroll down if you don't see them all. And I'll leave those up for just about a minute for the guests to respond, and then I'll share the results again. Okay, we're just at about a minute now, so I'm going to share the results. And Professor Anderson, if you wouldn't mind doing the honors again and taking us through these.
Well, again, it is the appendages that are truly isomeric. So obviously people are not yet convinced that that is the case. And you can't use the veno-atrial connections to determine arrangement. So this is very good. That, nearly 9/10 are in agreement there. Now, this is the real problem because, as Jim said in his excellent presentation, when you look at it surgically, I guess that in the clinical sense, if the veins come back to the heart in the setting of right isomerism, that's not being considered as totally anomalous connection. Whereas to me, anatomically, it is incorrect because they never come back to the heart in totally normal fashion. So this probably reflects the fact that in just over half, they go to an extracardiac site. In just less than half, they go the same. And then here, disappointing to note that everybody is expecting to find interruption of the inferior cable vein, but at least we saw that we are in agreement that the hands are the exemplars of bodily isomerism. So that's still a way to go, but we're making progress.
Great, thank you so much. So with that, I'm going to kick off the second half of our program. I want to introduce our next speaker, Dr. Antonio Amodeo. Dr. Amodeo is the head of heart failure, transplant, and mechanical circulatory support at Ospedale Pediatrico Bambino Gesù in Rome.
Well done.
Hello. Can you hear me?
We can hear you.
Okay. Good morning, good afternoon. I'd like to thank Sasha, Agati,
And Antonio, we may need to adjust your mic. We may need to adjust your microphone. It's
Can
coming
you hear me?
rattled.
Can you hear me now?
It's still rattled. Are you using the computer or your phone?
The computer. Let me check.
Yeah, your audio is fairly distorted. So if you click on the up caret in the lower left-hand corner by mute and join by phone audio, you should be able to call in, and we can pause for a moment and use that. Alternatively, if you have a headset with a microphone, that could work as well.
Can you hear now? It's okay now?
No.
No.
Lowell, why don't we flip orders?
Sure.
And then we can maybe get Antonio a headset.
Yes, please.
Sure.
Okay.
Sure. So we will we'll proceed and we'll just rearrange the order of the cases. So right now, we're going to talk about a nightmare heterotaxy case. Our speaker is Dr. Aurelio Stefanaro from the Department of Imaging at the same hospital, Ospedale Pediatrico Bambino Gesù in Rome.
Good afternoon, everyone. Can you hear me?
There's a little bit of echo, but we can hear.
It's Antonio, Lowell.
Can everybody else?
That should do it.
Okay, can you hear me? Hello, everyone.
Yes, we can hear you.
Okay, good afternoon. And thanks again for the kind invitation. I'm very pleased to participate to this webinar. I mean, and I'm obviously very keen of talking about the contribution of the cardiovascular MR or the tomography, advanced cardiovascular imaging in the evaluation, the complex evaluation of these patients. And today I will talk about this 2-year-old boy with a complex Electrophysiology syndrome. And I was just starting by showing you this these few images that we do at the very beginning of the scanner, as Gil said at the very concluding his presentation. So it's obviously a good overview on complex abnormalities in the laterality of the organs, both in the thorax and in the abdomen, as you can see here. And the MR and CT are beautiful representation of these complex combination of abnormalities in organs disposition and venous and arterial connections. At the same time, sometimes it's very it's very difficult to interpret this data when you are facing with these cases. So again, I think it's very useful sometimes to change your perspective and to change your point of view. And I think flipping over the images is something that you can easily do with your technical advances and your softwares by recognizing that sometimes the destrocardia can be flipped over in a level cardia, and you can of course recognize abnormalities like the position of the arch, or for example, like in here, you can notice that the superior vena cava is connected to the wrong side atrium. Anyways, this is just an introduction to say what you can roughly understand by having a quick look on the very rough images. About this case, I just want to start with the cardiovascular findings. And this is a 4-chamber view that is showing that this patient had a biventricular morphological heart with the L-loop arrangement. So the anterior ventricle is the right morphologically right ventricle stands anteriorly, and to the left is normal in size apparently, and while the posterior ventricle looks like it's the left in this case, and the apex is pointing towards the right side, and the heart, as you can see here, is standing on the right side of the chest. At the same time, we could notice from our anatomical images that there was together a combination of information from the echocardiography and the MR. There was a larger subaortic VSD where the ventricular arterial connection from the ventricles and the great vessel were concordant, and there was right anterior pulmonary artery with a mild infundibular level of obstructions here. So there's a flow acceleration in this oblique view of the RVOT, which shows flow acceleration at the level of the ostium infundibuli. So there was also left-sided aortic arch, but the most important part of this congenital anomaly was the presence of complex anomalies, systemic and pulmonary venous connections that were, first of all, they were unobstructed, but were very complex in their arrangement, as we said. So we recognize the IVC interruption with azygous continuation, and also both SVC and the hepatic veins were connected to the right side of the atrium here. As you can see in both these images, black blood here and this angiogram here. And this atrium was facing with the left ventricle and the systemic circulation. At the same time, we recognized that pulmonary veins were sided on the right side again and connected to the right side of the atrium and again to the systemic circulation. While on the other hand, the left-sided pulmonary veins were connected to the left-sided atrium, and this left-sided atrium was facing with the RV and the pulmonary circulation. Just going just below the diaphragm, where we can again recognize anatomically that there are very peculiar abnormalities in the arrangement of the organs. Especially, we could recognize the right-sided bilobed spleen with a predominantly left-sided liver, and the right stomach here, a dorsal rounded edge pancreas, which is in keeping with dorsal pancreatic hypoplasia, and abnormal arrangement as mesenteric vessel in concordance with what is discussed about the gut malformation that is happening in this case. And what we could recognize about atrial appendages and bronchi in this case was the morphology of the appendages on both sides. So that was very similar again. We couldn't really spot and highlight Pediatric muscle because the resolution of the technique is not enough. But at least we can say that there are similarities in this chicken wing appearance of this appendage. At the same time, we could really, with some difficulties because of bronchial compression, we could recognize the shape of the bronchial tree on both sides and their relationships between the branch pulmonary arteries in both sides. So I don't know if it's possible. I just propose at this time a question, and I don't know. Thanks. I think now we can start the poll for this case. So the question is very easy. How would you classify, segment this heterotaxy patient, both combining what we just saw before with Professor Anderson, and what is your opinion, and also giving additional information about the the position of the heart and the segmental analysis approach. So I think we can start the poll. So is it the left atrial or bronchial isomerism dystrocardia, ALI, or undefined isomonas heterotaxy, or right atrial bronchial isomerism with levocardia, ADD, or left atrial bronchial isomerism dystrocardia, ALL. Just wait for me a few minutes to see what people think about this. Of course, there might be some different opinion. We have the answer. Sometimes it's very difficult to interpret the data, especially for the morphology of the appendages. But I think combining all the information, we can definitely give an impression. Okay, let's have a look at the results. Okay, so some of the people, so the right answer is the very first one, so that a lot of people just got it right. And most of the people were confused by maybe the segmental approach, but it's, of course, they were very similar, so it's not a major issue. Maybe the arrangement of the ventricle was concordant, so there was not real transposition of the great vessel, so that's why this is totally different. But I think it's a very good result. So moving on to the next slides, I just want to highlight what is this pathophysiology of this patient, what is the difficult part. So I put all the information we got from the MR, and I just got just to highlight what is the distribution of the unoxygenated blood coming back from the systemic veins into the right side of the atrium in this patient. And from clinical and hemodynamic data, we recognize most of the systemic blood was going towards the right side in atrium and the left LV and the systemic circulation. At the same time, we tried to recognize and to figure out what was the distribution of the blood from the oxygenated blood from the pulmonary veins. And of course, there was splitting into both ventricles symmetrically. So I then look at the numbers from our clinical data. So we recognized that there was a sort of unbalanced distribution of unoxygenated blood, predominantly towards the systemic circulation, and giving a sort of a TGA-like physiology. So by summarizing, so the saturation in the aorta were lower 80s, while the pulmonary artery saturation was very high. So by concluding, summarizing our cases, I think this is a case of complex heterotaxy with left isomerism with a discordance. So the venous arterial connections in this case, especially from the systemic venous connection and ventricles, were unfavorable. And for this reason, the patient was a sort of TGA-like physiology, which was sort of compensated by the pulmonary anomalous pulmonary venous drainages on the right side. At the same time, there was a BSD infundibular obstructions at the level of the ventricle in a sort of a pink fallow physiology. So my last question then would be in this complex anomalous connections. So based on the information provided, of course, we can't really, we need more hemodynamic information probably to have a better overview. But based on this, how would you treat the patient? So would you leave the patient like this, or start with go for an atrial switch palliation, so that a palliative master procedure, for example, or maybe going for a functionally single ventricle palliation with a Kawashima operation plus a transeptectomy, or at last, I think a complete repair, either single or multi-stage repair, starting with the atrial switch and a VSD closure plus infundibular patch. What do you think about this? So for sure, it's not difficult to get the right answer, but at least based on the information provided, I think the deoxygenated blood going to the aorta is the main issue in this patient. So probably the redirection of the flow at the level of the atrium might be definitely good thing for the patient. Yes, that's right. So basically, I think the last one is the correct answer, even though we miss some of the information. But even the atrial switch palliation as a start is a good thing. But of course, in this setting of biventricular circulation, I think this is definitely the correct answer. Thanks for your attention. My presentation is finished.
Great. Thank you so much. And thanks especially for sharing those beautiful cross-sectional imaging. So as is no surprise at this point, we're going to change up the order a little bit. Dr. Belli, are you available?
Antonio, we're going to do the other case and then have you come on if that's okay.
Okay.
Gil,
Can you hear me now?
Gil.
It's a little bit better.
I'm here.
Yeah, but your name is mine, Emre.
Really?
Dr. Wernovsky has magnanimously shared his login for many of our
I was dreaming on it from many years.
Dr. Belli, are you ready to present your case?
Yes.
Excellent. So Dr. Emre Belli is going to join us presenting an additional nightmare heterotaxy case. He's the head of pediatric cardiac surgery at Marie Lanneloungue Hospital in Paris.
I'm sorry not to know. I will share my. I will just share my screen.
Ciao.
Is it working?
Not yet, Emre.
And now?
Yep.
Yep.
Okay. I didn't know that this technology with multiple choice simultaneous audience questions. So I ask you to keep your microphone open and in old fashioned to jump as in answer. It's a nightmare case, which emphasizes that the lung disorders in the setting, which for us surgeon influences a lot the indication and also the outcome. So this is a case with heterotaxia, more likely left atrial isomerism. However, the bronchus, despite situs inversus, were in situs solitus, and polysplenia, which was investigated too, interrupted aortic arch, common AV septal defect with 2 ventricles, no TAPVC, and anomaly of the systemic venous return. Born prostaglandin transfusion at birth and transfer for surgery. This is the echo image prior to first procedure, and the interrupted arch was type B, and the patient was 3 kg. There is a left aorta, descending aorta. The great arteries were anteroposterior, a little bit, not exactly the mirror image, some malposition. However, aorta from left and pulmonary artery from the right, and the descending aorta on the left side. What would you do as prenatal surgery?
Why don't I ask Dr. Kirklin, because I think if we ask 470 people, Emre, it'll be a disaster. Jim, do you want to comment? If you're still there?
I'm terribly apologetic. I had to step away for a phone call, so you'll have to continue. Maybe Lorenzo, you could.
But I know partially this case, so I know what he did. We discussed yesterday. But probably you have to fix the arch and maybe bending, or in alternative do an ortho procedure. I don't see very well the subaortic region. The choice would be related to that.
So let's go. We did what you expected. We did the arch repair, direct anastomosis and pulmonary anterior bending, which is, of course, not the same issue when the VST is not closed. So very rapidly, this patient came back with double obstruction due to bending and the conal septum narrowing totally the subaortic area. dealing more than up to 5 meters per second gradient, 8-week-old. What would you do next, Sasha? Let's say. Let's show the options. Okay, we did a Norwood-Sano procedure. We were obliged to do Leconte maneuver while the pulmonary artery was directly connected to the very close to the descending aorta, and with the patch enlargement, we were afraid to stretch and occlude this left pulmonary artery. And we use a 5 millimeter mercury conduit. So this is at 6 months, this child had always, she stayed in hospital because of parental complication. However, remained cyanotic during all this time, requiring oxygen therapy and nasogastric feeding. These images are at 6 months. The cardiologist asked us to do something because the cyanosis was significant and influencing the status of the patient. What will you do next? The alternatives are listed here.
So we don't have these as interactive poll questions, just in case the audience is wondering.
Unfortunately, yeah. Because I didn't know that was possible in this way, despite the, didn't understand the message from Gil. So the options to evaluate was the anatomical repair at 5.8 kg, the cavopulmonary shunt, including azygos continuity, BT shunt, or any other option. So we remain simple. We add a modified 4 millimeter BT shunt. The patient improved a little bit his saturation, however, remained cyanotic until 14 months old of age, had a gastrostomy, additional non-invasive ventilation in the evenings because she was cyanotic with some overload, hemodynamic overload. And at 14 months, he was proposed for procedure. The alternatives were intracardiac buffle to tunnel the LV to the PA and reconstruct the RV outflow. Something like a root replacement or a root rotation, and cavopulmonary shunt, including azygos continuity in a 70% oxygen-dependent patient.
Given our time commitments, yeah, let's try to move things forward.
Let's move on. So we did the Kawashima shunt. Then after story continue because it was cyanosis persisted and it was discovered infradiaphragmatic venous return anomalies with accessory IVC, which was occluded the year after, and another cavopulmonary renal artery cavoportal fistula in the year after. and the RPA, probably due to the Leconte maneuver, was stretched, and a stent was placed at that level. The patient remained always cyanotic and oxygen dependent until 4 years of age, 13 kg, where we observe the evidence of mainly left-sided pulmonary arteriovenous fistula in angio. The options were similar, still anatomical repair, which was abandoned after intracardiac inspection during the Kawashima repair at 14 months of age, because the rerouting the LV to the pulmonary artery appeared to be not appropriate, and to do something like Mikaido in this setting with a severe cyanotic patient was more than advantageous with AVSD repair adventure. Thus, we developed the images in order to discuss a connection with the separate two pulmonary veins to the RPA in regarding to the superior caval anastomosis, or to the azygos vein, which was chosen under bypass. We collected both vein without cross clamp on a conduit and terminal, which was anastomosed below the aorta to the azygos continuity. Procedure was uneventful. The patient came in the ICU with the same saturation as you expected. In good times, 70%. However, there was a short time period with left pleura drainage dysfunction, which was immediately recovered. However, the patient continued to become hypoxic, and as we previously stated that no additional support maneuver would not be applied in this setting. We lost the patient due to refractory cyanosis despite favorable hemodynamics and probably massive opening of the arteriovenous fistula and one side line, which is the main challenge in this particular setting. That's it. I was very fast.
Great, thanks for that great presentation. And despite the unfortunate outcome in that last case, I'd like to remind all of our guests today that we do have 3 sections still coming up with great speakers: electrophysiologic considerations, transplant, and outcomes of the Fontan operation. So thanks to those of you who have joined us, and please stick around. So Antonio, are you ready to begin your presentation?
Yes, okay. Can you hear me now?
Yes, we can hear you great. So Dr. Amedeo is going to speak to us about challenges in cardiac transplant when there's abnormal venous connections.
Okay. Emre, can you close? Okay. Okay. Back again. Good morning or good afternoon, everybody. Thanks to Sasha and Gil for giving me the opportunity to participate to this very interesting webinar. And Sasha gave me this talk, challenges in cardiac transplantation when there are abnormal venous connection in isomerism, donor to recipient consideration. Well, I would like to give an introduction because I believe that the technical point are really important, but probably is the preparation to the technical endpoint is probably much more important. So when I believe in the transplantation in congenital heart disease, in complex congenital heart disease, I think it will be extremely important, the donor management, the assessment of heart transplantation, and of course bleeding. Probably the most important thing are to plan the heart transplantation technique and plan the vascular access, the difficult chest sometimes, PN, caval vein reconstruction, and so on and so on. Of course, when you look at the transplantation in congenital heart disease, the bleeding sometimes is the main issue. Dissection usually should be undertaken without resorting to cardiopulmonary bypass. Prepare but avoid femoral or subclavian cannulation. And of course, we're talking about control cross-stamp time and all surgical reconstruction before donor heart arrives. And of course, avoid undersizing.
Antonio, your video is only showing the lower 25% of your screen.
Only 25% of the screen?
Roughly. If you just exit your slideshow mode, in the interest of time, I would say manually advance the slides just from PowerPoint itself, because we could see your monitor fine before you entered slideshow mode.
And here? Is okay here?
No, I'm still just seeing a blue background with some yellow text.
Let me check. How is the situation now? The same.
It's your video isn't quite working.
Here?
I'm going to stop your sharing and just restart it, and we'll see if that helps.
Okay. How is it now?
Still the same.
Let me check again. Wait a second.
When you select your sharing, it'll give you a menu of what you want to share, whether it's your whole monitor or just the PowerPoint application. So just choose the PowerPoint application.
Okay, let me check now. Okay. Yes, they said portion of screen, yes, correct.
So now you're sharing your self view of the camera, but that video worked okay.
Now it should be okay, correct?
Perfect,
Okay.
thank you so much.
Finally, well, what I believe is extremely important is the CT scan for reconstruction. Of course, you need to plan additional surgical reconstruction, planning stellar reentry, of course, planning pulmonary artery reconstruction. Of course, when you need some trip and tricks, you know, when you face complex congenital heart disease transplantation, and of course, you had to face with dent adhesion, cyanotic patient with systemic two pulmonary collaterals, especially in posterior mediastinum, that result in increased pulmonary venous return, which may compromise exposure during surgery. And conventional transplantation technique may not be possible in the context of a congenital heart disease because of unusual anatomy and its social or value structure by previous surgery. So what is extremely important is the hemostasis. You should be extremely meticulous. Of course, you need the extra donor tissue that may be needed for the reconstruction. Of course, you need the extra length of the donor aorta, including the arch, sometimes. Extra length of the pulmonary artery, including the right and left VA. Extra length of the superior vena cava with or without the nominate VA. So what I believe is that an accurate preoperative anatomic evaluation and the planning of heart transplantation in complex congenital heart disease is extremely important. Probably the CT scan is the best way to achieve this, but of course you have to do a pre-planning for extremely complex cardiac operation. Just to have an idea, this is the paper from Joseph Gerani talking about the mortality compared to the different sternotomy. And you can see here, you can see that the mortality can reach 10% when you are over the 5th sternotomy in this patient. So you have to be extremely careful because everything can happen. As you can see here, the LRD just close to the sternum. And of course, everybody in your life, it can come one time in your life, but you can make a really disaster. So let's go now to briefly go to the technical point. And of course, this is the most simple things that you can have in isomeric patients is the left superior vena cava and the right superior vena cava present. Of course, this is very easy. You can have an extra length of innominate vein during the removal of the donor heart. And of course, you can see here the can be brought back to the recipient right atrium by utilizing the donor innominate vein. And this is usually very simple, very easy, but sometimes it's not so easy because sometimes you can have a very big aortic arch and it can make an occlusion of the innominate artery. And this makes it extremely difficult when the donor innominate vein is not sufficient in length, or if the return from left superior vena cava is going to exceed the capacity of the donor innominate vein. This is usually in heterotaxy and interrupt inferior vena cava with the hemiazygos continuation. And of course, sometimes some cardiac surgeons advocate an intraarterial baffle can be created to redirect this systemic venous return. In our experience, we always, even in this condition, we have been able to redirect the left superior vena cava with the hemiazygos continuation on the right side without any intraarterial routing. But of course, sometimes you can have a little bit more difficult situation. This is a left isomerism inferior vena cava, interaction with the azygos vein continuation, bilateral superior vena cava, double out right ventricle, complete heavy canal, pulmonary stenosis in isolated dextrocardia. You can see a very big right superior vena cava, very big aorta, and you can see the compression of PA, left superior vena cava. And of course, this is after the cardiac transplantation. The aorta is still impinging the pulmonary trunk. And of course, this is because you have to do something different when you do this kind of transplantation. In this case, of course, when you have a very big aortic arch, we have to do a resection of the arch, and of course, make a reduction of the aortic arch. Of course, you have to extend the pulmonary artery along the left PA just to move the PA trunk from the aorta. And of course, then you have to reconnect the left superior vena cava to the right side, and you can do by the innominate vein or a little bit utilizing the right atrial wall to enlarge this. The group of Tennessee showed that probably in this case, extremely useful could be the CT scan, what we said before, just to have to calculate the dimensional volumetric analysis used for the effective mediastinal volume, and the mediastinal volume are usually manually outlined in this case with the dot blue line. And of course, you can have the actual recipient and the hypothetic donor just to see if the things are matching, and of course, you have the very good donor for your specific patient. But this is the case in dextrocardia and the heterotaxy syndrome. And of course, you can see the important is the cannulation. Of course, you have to cannulate the right AVC, the left AVC with the, of course, you can see here with the hemiazygos continuation. And of course, the incision on the pulmonary artery can be on the left side. And of course, you have to cannulate the hepatic vein. In this case, of course, you have to connect the left supinal cava on the right side, but sometimes in this case, you need a tube. You can use whatever you want. You can use Contegra, you can use Gore-Tex, whatever you want, but sometimes you need a connection. And of course, even for the hepatic veins, you need or you can use the atrial wall, or you can use a baffle, or you can use whatever you want to reconnect the hepatic veins on the right atrium. So as you can see at the end, the technical difficulty are present, but if you plan a nice preoperative assessment with a very good imaging, I think the situation can be easily managed. This is the case in situs inversus, as you can see here. You have to use a right atrial cuff to form the E6 channel, and of course you can see the left atrium can be divided with the different anastomosis of the can be separated to donor left atrium anastomosis. Of course, the ostium, as you can see here, so the inferior vena cava, you have to create a composite tunnel. You can use partially the right atrium, partially a patch, or what is more convenient for you. And as you can see here, sometimes you need a conduit to connect left SVC to the right side. In conclusion, patients with abnormal venous connection, dextrocardia, site inversus, pose significant surgical challenge to a successful autotomic heart transplantation. What I believe is extremely important, an accurate preoperative anatomic evaluation and planning. This is really mandatory. Thank you very much for the attention.
Fantastic. Thank you, Antonio.
Oh, thank you, Antonio. So we are going to, we've talked a lot about the anatomy, and Gil started off his session about talking about how many consultants a patient with isomerism or heterotaxy requires. So our next two speakers will help address the question of how many cardiologists a patient with heterotaxy or isomerism requires. So our next two speakers are going to address electrophysiologic considerations in isomerism. First will be Dr. Corrado Di Mambro, who's the head of pediatric cardiology at Centro Cardiologico Pediatrico Mediterraneo in Taormino, followed by Dr. Charles Barul, who's the chief of pediatric cardiology and head of the Children's National Heart Institute at Children's National Hospital in Washington, D.C. So Dr. Di Mambro, you are up now.
Thank you. Hi. Good morning and good afternoon, everybody. Thanks for the invitation. I don't have a presentation. I'll be quick. Defects in the conduction system are highly prevalent in the population with congenital heart disease. Heterotaxy syndromes are associated with complex cardiac malformations and often present abnormalities in anatomy and functioning of AV conduction system. And attempts to predict the nature of the conduction system may be fraught with difficulty, given the extreme heterogeneity of this population. The sinus node is nearly always abnormal in terms of number, morphology, or location. For example, in patients with left atrial isomerism, the sinus node could be absent or hypoplastic and ectopic in location. The anatomic roots of AV conduction in heterotaxic syndromes are also highly variable, and these often with anticipated and penetrating bundle branch and or presence of Monkenberg sling can predispose to various arrhythmias. Indeed, AV block is often associated with left atrial isomerism, while cases of AV reciprocating tachycardia mediated by twin AV node are more frequently associated with right atrial isomerism. Finally, in heterotaxic syndromes, we must also consider iatrogenic arrhythmic complication. I have the pleasure to introducing the presentation of Professor Barul, focusing on this complex topic. After its presentation, we may start a short discussion, and I will reserve the possibility of some questions. Thank you. You can start, please.
Thank you, Corrado. Charlie, I see your screen, so whenever you start your presentation, you should be good to go.
Looks great. You're muted, Charlie.
Good. So thank you for inviting me, and thank you all for staying on the presentation. As many people see electrophysiology and they think that's time to take a break. So for those of you who haven't left your seats, thanks. This is going to be brief and going to highlight some of the issues such as what Dr. Dimambro brought up. One of the things we have to think about in electrophysiology is that children aren't just small adults. And so when we're planning EP procedures, we have to remember that these children with congenital heart disease hopefully grow into adults with congenital heart disease. So we need to plan early for decades after the procedure so they don't end up with an X-ray that looks like this one. In this paper from the Pediatric and Congenital EP Society and Heart Rhythm Society, there's a great diagram that many people use to highlight some of the rhythm issues to consider in congenital heart disease. And right up at the top, under sinus node, it talks about abnormal in isomerism. So it's a key feature, and we're going to get into each of these in a few minutes. And then under AV node, abnormal location in physiology, the potential for twin AV nodes and other conduction system abnormalities. In the same paper, they graded the degree of arrhythmia risk based on the type of congenital heart disease from simple to moderate. And heterotaxy makes it all the way to the bottom of the list, where there's a high incidence of atrial tachycardia, AT, you see in the dark blue, atrial fibrillation in the medium blue, sinus node dysfunction in the dark blue, and dyssynchrony in the dark blue as well. So a high risk for multi-level types of arrhythmias. And we'll go back to one of Dr. Anderson's paper, looking at where is the sinus node. And in the upper left half of the screen, or in anatomic position, and the upper right half of the screen, the normal situs, the sinus node lives in the upper right corner of the atrium. And you see the pectinate muscles in the morphologic right atrium there, and the normal left morphologic atrium on the left side. In situs inversus, the mirror image atrial arrangement, the sinus node typically lives on the left side of the atria. And what you'd see on the electrocardiogram is an ectopic atrial rhythm, or a left atrial rhythm, often with a normal rate, because the sinus node typically is still functional. In other words, there's rate variability and automaticity that just comes from the left side. There may be sinus node dysfunction associated with it at times as well. For right isomerism, or isomerism of the right atrial appendages, you may get bilateral sinus nodes typically, and you will have on the electrocardiogram what looks like a wandering atrial pacemaker, or two different P-wave morphologies, because there's two different competing sinus nodes, and whichever one is slightly faster is the one that's going to win the race. Conversely, with left isomerism, because of the isomerism of the left atrial appendages in the left side, there is not a sinus node typically, or there may be a very hypoplastic sinus node because of the absence of development of the right atrial electrical system. And you typically get sinus node dysfunction. So on the electrocardiogram, you'll see either a low atrial escape rhythm or a junctional escape bradycardic rhythm as the presenting ECG. In terms of the AV node in development, this is an elegant diagram by Shirashi and colleagues from Japan, looking at early transcription factors and how this drives left-right development. There's a variety of transcription factors here, and it's too short a time to go into the molecular biology and developmental biology, but to be brief, normal leftward nodal flow occurs in situs solidus, where the transcription factors shift those leftward genes to promote left-right development, and in situs inversus, they get rightward nodal flow or right dominant distribution. Whereas in the heterotaxy syndrome, it's somewhat random, and those genes aren't left-right separated and can occur in a variety of fashions, which is why heterotaxy can have a wide range of electrophysiologic and anatomic manifestations. One of the unique electrophysiologic issues that Dr. DiMambro alluded to is twin AV nodes. And several people get this confused semantically with dual AV nodes. So I wanted to spend a minute to clarify the difference. Many of us have dual AV node physiology, where it's a single AV node that has differential conduction with fast conduction and slow conduction, which is why it's called dual AV node physiology, going in the anterior and posterior direction of the single AV node. And that can lead to AV nodal reentry tachycardia, the most common kind of reentry tachycardia in teenagers and children with a structurally normal heart. And so that's different than this very rare form of twin AV nodes, where there's actually two distinct AV nodes. Typically one's anterior and one's posterior, and typically what separates them is a defect, typically an AV canal, an AV septal defect, or a large VSD, and there's an AV node on top of and below that structure, giving twin AV nodes. And they can compete with each other just like when you have two sinus nodes. And the way to distinguish them on the electrocardiogram is the QRS axis and morphology. And so it's when the conduction is going through the anterior AV node, the QRS axis is normal. And when it's coming through the posterior AV node, it's a superior axis, as you would expect in the, for example, an AV canal defect. And it makes sense if you look at the picture why the QRS axis would be different depending on which node is conducting from the atrium to the ventricle. Now in this diagram from the Walsh textbook, they show the Monkenberg sling. Monkenberg described this in 1913, so over 100 years ago. He was able to elegantly describe this sling-like structure from pathology, showing connections between these two AV nodes. This is important because you can get a type of supraventricular tachycardia called twin AV nodal tachycardia, where the beat conducts down one and goes back up retrograde through the other, causing a reentrant circuit. And to fix this, you can either treat with medications just like you would any other type of SVT, or for catheter ablation, you have to get rid of one of the circuits, typically the less dominant circuit. Not to get into too much electrophysiologic detail, but the one with the higher refractory period, one that blocks earlier, is typically the one we would try to get rid of, or catheter ablate, leaving you with a single normal AV node. If you get rid of the other one and leave the weaker one intact, you may end up with progressive AV block and the need for a permanent pacemaker. To make matters even more complicated, each of the two twin AV nodes, either or both of them, can have dual AV nodal physiology. And you can get both twin AV nodal tachycardia or dual AV nodal tachycardia within the same patient. And so you have to check for dual AV nodal physiology like we see in many people, along with the rare twin AV node tachycardia. In this recent paper from Carey's group, they show this beautiful picture on the left, which is an MRI superimposed on the three-dimensional electroanatomic map to overlay them. And from the anatomic standpoint, you see the intraatrial conduit that goes from the confluence of the hepatic veins up to the pulmonary artery. And then in this patient, there's a double outlet right ventricle. They've marked in purple dots right in the middle of the heart, the normal superior AV node, And then in light blue dots at the bottom, the inferior AV node, showing a circle of re-entry that can occur between the two AV nodes. And in the electrocardiogram on the right, you see after the third beat, a little asterisk, and that demonstrates the shift in the direction of conduction, going from an inferior axis to a superior axis without any change in the rate. And so this is not a termination of tachycardia, it's a change in AV conduction going from the posterior node in the first few beats and then shifting and going from the anterior node in the following 4 beats, a demonstration of twin AV nodes in heterotaxy. This gets very complicated when trying to put in pacemakers or defibrillators in these patients because of their abnormalities in venous and intracardiac anatomy. In this picture, you see the 2 most common ways to put in pacemakers transvenously. If there's a venous connection from the cava to the atrium or ventricle, and epicardially if there's either venous abnormalities or the patient's too small for transvenous routes. And then on the bottom, the newest iteration of pacing, the leadless pacing, where there's a pacemaker that's placed via a catheter and delivered to the right ventricle. Similarly, for defibrillators, there's now 4 or 5 ways to put in defibrillators in children. The transvenous approach that you see in the upper left corner of the box. The lower left corner shows epicardial patches. The upper right corner shows a subcutaneous array. And the lower right corner shows a pericardial coil in the posterior pericardium. And the offset one shows a patient with heterotaxy and dextrocardia and a subcutaneous ICD, again, placed on the right. It's not that the chest X-ray is inverted. So you have to be prepared because venous anomalies are so prevalent in heterotaxy. Here's a patient with a left superior vena cava going to the coronary sinus with no bridging vein and no right superior vena cava. And so the indication for transvenous pacing, they had to put the pacemaker through the coronary sinus to attach to the right atrial free wall, and then a loop-the-loop to get in through the tricuspid valve and down to the ventricle. Sometimes you just can't get there. Here's a heterotaxy patient in the cine with dextrocardia transposition who's undergone a mustard-type baffle and lots of epicardial leads that now requires a transvenous pacemaker. What you can see from this cine in the baffle is severe obstruction about midway through the baffle. And so it's important to coordinate with your surgeon and or interventional cardiologist so that you don't put a lead through that stenosis, and first fix the stenosis before putting the lead in. And if you're using a stent, to stent first and place the pacing leads afterwards so you don't jail the pacing leads under the stent and never to be removed again. Similarly, in an extracardiac conduit, as in this diagram here, the Gore-Tex conduit is going to prevent transvenous access of pacing to the heart. The way Dr. Jonas has described it, using an intra-extracardiac conduit, you still can access viable right atrial tissue when transvenous atrial pacing is indicated in some of these complex heterotaxy patients. So in heterotaxy, sometimes you have to be creative and you can't use out-of-the-box devices and leads. And that's really the point of this short presentation, is not being able to do this in a standard fashion. There's been lots of progress over the past decades. If you think about it, we used to watch television in something that looked like this. And now 50 years later, this is the way many of us are watching television. Some of you probably watching right now. So things in electrophysiology are going to progress over times as well. This old defibrillator is not that old. It's only about 22 years old. And we see significant progress going in terms of miniaturization of devices and customization for children with congenital heart disease. So I'll stop here. Dr. DiMambro and I be happy to take any questions about the electrophysiologic implications. Thank you.
think we're going to have to do that offline,
Okay.
Charlie.
I will stop sharing my screen.
Thanks. Thank you, Charlie. Thank you, Corrado. That's a really nice overview, not only of the electroanatomical abnormalities, but the really pragmatic challenges that exist when somebody requires pacing or defibrillation. So I believe we're ready. Dr. Raisky, are you on the session? If you are, just unmute for a sec. I did not think so. So we're gonna now move on to our final speaker. Dr. David Winlaw will be speaking about outcomes of the Fontan operation for patients with heterotaxy. Dr. Winlaw is professor of cardiac surgery at the Children's Hospital at Westmead in Sydney, Australia, joining us at some ungodly hour right now. Dr. Winlaw, thank you for joining us.
Thanks, David. Is it 1:30 in the morning where you are? I think you're still muted, Dave.
Yeah, can you see my screen?
No, we can.
Permissions issue here.
We still see Charlie. Here we are.
Hi, can you see me?
Hello.
Hello.
Don't see you.
Hello.
Don't see you quite yet. Sorry, somebody else has jumped in. I will attempt to fix that.
Now we see you.
Hi there. Can you see my PowerPoint?
We will in a second. Yeah, you're good.
Okay, great. Thanks very much for the invitation to participate in this great webinar today. It's a good time to be speaking together, and although it is 1:30 in the morning, it's certainly easier than catching an airplane to Europe or America at the moment. So I'm going to touch on some things that have been mentioned by the previous speakers, so I think I can keep it fairly fast. I want to first acknowledge some major contributors to the work that I'm presenting. Dr. Supreet Marath, who I think is on the call, and Dr. Jacob Cow, and of course my colleagues, including Yves Dudikem at the Fontan Registry in Australia and New Zealand. Many of these concerns for surgeons have been mentioned before, particularly cardiac position. I think particularly relevant to the single ventricle group, the AV valve regurgitation and ventricular function are major issues. Many of these others have been mentioned already. But I want to start off by posing this question, and it might not be possible to get an answer here, but let's imagine a patient who we've managed, is a 2-month-old who presented with this set of, if you like, the full house of right isomerism, the cardiac, supracardiac TAPVD, unbalanced AVSD, and pulmonary atresia with bilateral ductuses, and I think you can see that here in the CT scan. And I guess the first question is to ask whether you or your colleagues would offer such a patient surgery, because that's not always been the case in some centers. And in fact, in the home state where this patient was initially assessed, the decision was made that the long-term outcomes of Fontan circulation in this patient would not be good, and the parents were counseled for palliative management. The parents insisted that something be done. We were happy to do that and perform this operation, repairing the TAPVD, reconstructing the central pulmonary arteries with a Gore-Tex tube, and doing a systemic to pulmonary shunt. We were happy that there was a good outcome in that early phase. But I guess turning now to the substance of the presentation, what data do we have to counsel the parents about survival to second stage or beyond? I think these are important questions. And to the first paper I want to discuss is this meta-analysis that Suprit and Jacob did, looking at 21 studies. Many of the people on the call are mentioned or are authors on this list of studies. It's a difficult thing to do a meta-analysis in heterotaxy, mostly because all the patients are very different, not just their diagnosis, what sort of isomerism they have, but the kind of initial palliation that they require, whether it's pulmonary artery banding or a systemic to pulmonary shunt. And you can see also that the age at Fontan, which we know to be an important factor in many other contexts in terms of long-term outcome, is also very different through these series. Nonetheless, when putting all this data together, what we see is this very significant drop-off in survival early post-Fontan. And remember, this is after Fontan, not after birth. And you see, after this initial period of hazard, if you like, that the curve is a little more gentle. And if you compare that to our work looking at all sorts of Fontans in Australia and New Zealand, the slope of this curve is very roughly analogous to this curve. Now, that's not going to pass muster with a statistician, that kind of comparison. But I will get onto that in a little bit. Other things that we looked at which didn't come out as being important in the meta-analysis were that right isomerism, despite everyone's concern, did not seem to fare worse. So just to wrap up this part, one of the big issues that we've seen in this overview is that there's not very much long-term outcome data, and that really we're only looking at survival and not other indicators of life with a Fontan and other measures of failure. And so we looked at this in more detail in the registry. Just a brief word back to our baby that we managed, came back for second stage surgery, was assessed as being suitable for that. We upsized the central pulmonary arteries and we're happy that we're able to get that child through. Again, wondering whether this is cause for optimism. And if you look at the title of our paper here, you'd say that, yes, there's plenty to be optimistic about. We are essentially saying that heterotaxy is not a risk factor. And I think this echoes some of the things that Dr. Kirklin mentioned in his presentation. A few things to acknowledge about the Fontan registry. The first is that you enter the registry when you're discharged after a Fontan. We're not evaluating perioperative mortality. And we're certainly not including pre-Fontan mortality in this overview. But we did have 109 patients out of the registry as a whole to look at. And here again, there's some spread of both pathology and treatment pathways. But I think it's reasonable to say that the patients who had heterotaxy had their Fontans later, and they stayed in hospital longer. I think they're the critical points from this slide. And then looking at this composite endpoint, which includes death, PLE, plastic bronchitis, transplantation, being in a high functional class, Fontan takedown or Fontan conversion, you can see when the two groups are compared, over a reasonably long period, we're not able to demonstrate a difference between the heterotaxy and the non-heterotaxy. And so the value of this is very, very long follow-up in very similar groups of patients. I just want to step through again to look at expectations at our baby who came for their Fontan, pre-Fontan catheter. And you can see the reconstructed pathway is not looking too bad. You can see the pressures in the pulmonary arteries are satisfactory for Fontan completion. And at the age of 4, with saturations that weren't too bad, but were going down during exercise, we asked the question, is this patient suitable for Fontan and should we fenestrate them? I think they're two critical questions. We didn't see an exclusion for completing the Fontan. we decided not to fenestrate, which is a decision that we may later regret. So we performed a standard extracardiac conduit, reconstructed the pulmonary arteries, did a bit of tidy up. There were some chylous pleural effusions, but the patient got out of hospital within 2 to 3 weeks. Thinking about the longer term now in the Fontan group, looking at the heterotaxy patients, we did identify an increased rate of supraventricular tachycardias. And that will not be a surprise, particularly given the previous presentation. But when we look at some of the work from the whole Fontan registry, looking at what it means when you start having a supraventricular tachycardia, it's really the beginning of more difficult things. And you can see a much accelerated drop-off in freedom from problems once a supraventricular tachycardia is experienced. We did try to get some more granular detail to make sure that what we were seeing when comparing the two groups was real. We propensity matched a whole number of arrangements. You can see that brought us down to a smaller number of patients for comparison. But again, we failed to show a difference between these two groups. And again, just like the meta-analysis, we weren't able to demonstrate a difference between the two forms of isomerism. So getting towards the end here, our baby, who is now a 5-year-old child, presented 6 months after their Fontan with this chest X-ray. And I think many of you would recognize that there's some problems here with this pulmonary vascular picture, particularly in somebody who's had TPVD repaired in the past. And then she coughed this up, and that's a bronchial cast. The usual post-cast investigations were undertaken, showing a nicely formed Fontan pathway. And of course, the pressures, as they often are pretty low in this situation. Fortunately, there was no ventricular dysfunction or AV valve regurgitation. Nonetheless, the plastic bronchitis persisted. Using the studies of lymphatic pathways, we demonstrated that this patient had a very abnormal pathway for lymph to travel from the cisterna chyli up towards the upper body veins. And there are also other abnormal plexuses of lymphatic drainage from the upper body as well, heading towards the major veins. But with disruption of the cisterna chyli, we were able to reverse the plastic bronchitis, although the follow-up on that is only about 6 months at this point. So I think there's enough evidence from the registry data and work presented by Dr. Kirklin to say that we actually need to rethink how we approach heterotaxy patients, and that the pessimism that many of us have might not be warranted. I insert this word, heterotaxy patients can do almost as well, because as I presented with baby X, you think you're doing really well and things go very nicely for a long time. But survival with the Fontan, free of all those concerns, we need that to persist for a very long time. And so looking at the quality of long-term outcome is extremely important. What can we do? What can we do differently? Well, I think this is more of an evidence-free set of suggestions. I think a lot of it comes down to diligence and trying to operate at the right time, trying to make the pulmonary arteries are as good as they can be, and don't defer the Fontan because you know it's going to be hard. I think that's not necessarily a good thing to do. So I'd be delighted to take questions, but I can see that's going to be hard. Thanks for your attention.
David, thank you very much, especially for being up at 1 o'clock in the morning and presenting this. I wanted to, if you would mind, stop sharing your screen for just a second. And I also wanted to make another point. I love your conclusions. Remember that we're dealing with groups of patients, and there are individual patients along those lines, and I'm really glad Alicia was on with us before to put some balance to optimism and pessimism, and we should never forget to look at the individual patients, not just the groups.
Totally agree.
Yeah, I'm going to just remind people, let me see if I can get this to share again. Lowell, is that slide sharing?
Yeah.
It is, Gil. You have the same problem I later learned I did, which you're showing the presenter view, but it's still perfectly legible. I think it's fine to proceed.
Okay, great. I just want to remind people before I turn it back to Sasha that, you know, we're learning as we go along with this technology. And while the COVID epidemic has been, the pandemic has just been dreadful in so many ways, nothing is always 100% negative or 100% positive, and there'll be some silver linings, in particular distance learning. The fact that we could have people on the call from 3 continents and multiple institutions gives a very good perspective. Dr. Agati is organizing the next masterclass in 2 weeks on hypoplastic left heart syndrome. We have everyone's email address. We'll be back in touch with the links. The faculty is in the process of being confirmed. I believe we have Dr. Pedro Del Nido and Norman Silverman confirmed at this point, and we're working on a number of people for the early stuff as well, so stay tuned for that. And then again, the faculty is confirmed for our masterclass on what I think will be a fascinating discussion, especially for young investigators, not only on the background methods, results, and discussion part of a presentation, but how one becomes an investigator, how one deals with funding, how one deals with politics of authorship, and a lot of things that don't get taught typically as the real world of clinical research. So Rick Oye will run this along with Sarah Jane, Jim Tweddle, and Karen Goldberg. That will be on the 26th, and I will send you information on that. The course was recorded by Lowell. We're going to be working on the details of how to distribute that. I'm going to ask the presenters, if they don't mind, to send me their presentations in PDF format if they're willing to share. If they want to send the PowerPoint, I'll make it into a PDF for people. And then probably within the next 48 hours, the papers that were referenced in these presentations will be included in a bibliography or course syllabus that we send to you. So I'm going to turn it back over to Sasha to close the meeting. And I want to personally thank everybody and all the speakers for what has really been a terrific experience. Dr. Agati.
Sorry.
Maybe, well, there you are.
Yes, sorry. Italian is not good. I will try to share. I want to share my screen. So we will be able to see the problem from different point of view. Also, Professor Anderson working with the exit poll directly on the screen was, for me, a real amazing experience. So the idea doesn't change, and as Gil said, we are ready to go on to continue our idea to make every 15 days, but we try to do all the best to be in contact just in this pandemic period, and I'm very happy for this. And again, thanks a lot to everybody. At the start, we try to prepare sort of paper or a slide where we can put all the people from all over the world they comes, but we were not able to do this because all the world was participating to this webinar. We arrived at more than 1,000 registrants. At the peak, we have more than 650 people working on the screen. So we are very happy for this, and I hope to see you very soon. Okay. No one is there? Hello? Hello?
Very nice, Sasha. Looking
Yes.
forward to the next one.
Yes, thank you.
Ciao, Sasha. Thanks a lot. Ciao, Sasha.
Ciao, ciao Nino.
Thank you so much. Take care.
Ciao
Thanks a
Sasha,
lot.
congratulazioni, molto ben organizzato e interessante. Ciao.
Grazie, grazie Pietro.
Grazie.
Ciao a tutti.
Thank
Grazie. Ciao
you.
Sasha. Thank you very much.
Thank you, Sasha. It was great.
Yes.
Excellent. Thanks,
Thank
Gil.
you, everybody.
Thank you so
Thank
much
you.
from Saudi. Thanks a lot.
Bye.
Thanks you.
Colombia.
Thanks very
Thank
much.
you.
Bye bye.
For the next time,
you, Sasha.
we will be better, no problem.
Thank you very much, all of you.
Very much.
Ciao Carlo.
Thank you so much from India. Thank you so much.
Thank you from New York City.
Thank you very much.
Thank you to New York
And
City.
thank you from heaven.
Thank
you. Thank you.
Thank you.
Brazil.
Thank you from Ecuador.
Thanks a lot.
Thank you from Algeria. Thank you, Professor.
Grazie mille.
Thank you from Nepal.
Nepal.
Grazie, Sasha, from Qatar.
Ciao. Ciao Grace.
From Bogota. Thank you.
Yeah, amazing.
Thank you from Cali, Colombia.
Wow.
Thank you from Athens, Greece.
Yes.
You guys are making your heterotaxy patient cry over here.
Good luck to everybody and
Thank you from Beirut, Lebanon.
Stay safe, everyone.
Yes. Good luck.
Thank you from Riyadh, Saudi Arabia.
Please try your best to get this meeting back to us in PDFs or whatever.